Dear all, Assalamu alaikum. This is Dr. Nushat Jahan. My today's topic, cervical circulars, and this has been taken from RCOG Guideline 2022. And today I will discuss about its types, indications, contraindications, and when to remove all the circulars. So let's begin. At first, we have to understand what is cervical circulars. It is a procedure by which we place a suture around the cervix to make it strong or tighten up. When there is any evidence of cervical weakening or cervical incompetency that may result in second trimester loss or preterm birth. So now coming to types of cervical circulars. We have history indicated circulars, ultrasound indicated circulars, emergency circulars, transvaginal circulars, that is also called McDonald stitches when it is put in the lower part of the cervix, and high transvaginal circulars when the stitches put at the upper part of the cervix, also called Cervical stitches, and transabdominal circulars that can be performed both by laparotomy or laparoscopically, and we have occlusion circulars. So now let's see when we can offer history indicated circulars to a woman. If any woman come with history of 3 or more previous preterm birth, we can offer her history indicated circulars. And it should not be routinely offered to a woman with less than 3 previous preterm birth or second trimester loss without any additional risk factors. So this history indicated cervical circlage actually depends on obstetrics and gynecological history of a woman. Let's see the timing of history indicated cervical circulars. It should be offered in between 11 to 14 weeks of gestation. And this is a planned procedure and it's done in the asymptomatic women. From this slide, we will know when should an ultrasound indicated circulars be offered. So let's see, women with a history of one or more spontaneous second trimester loss or preterm birth who are undergoing ultrasound surveillance of cervical length should be offered circulars if the cervix is 25 millimeter or less and the gestation is less than 24 weeks. So that means that any woman with a history of one or more preterm birth or second trimester loss and they are undergoing ultrasound surveillance and their cervical length is 25 millimeter or less and the gestation is less than 24 weeks, at that time we can offer her ultrasound indicated circulars. But the ultrasound indicated circulars is not recommended only for funneling of the cervix. That means where there is only dilatation of internal os without any shortening of the cervix. That means the cervix is 25 millimeter or less, means cervix is not 25 millimeter or less, so there is no shortening but only funneling. In that case we will not offer ultrasound indicated circulars. And also it is not recommended when there is short cervix and it is incidentally identified on a late second trimester ultrasound findings. So any incidental findings without having any risk factor in the late second trimester of ultrasound findings, in that case it's also not recommended to offer an ultrasound indicated circulars. Let's see who should be offered serial sonographic surveillance with a view to ultrasound indicated circulars. So women with a history of spontaneous second trimester loss or preterm birth who have not undergone history indicated circulars may be offered serial sonographic surveillance. As who experience cervical shortening, that means cervix is less than 25 millimeter, may benefit from ultrasound indicated circulars. And as I mentioned before, that women with preterm birth without any risk factor for preterm birth, the cervical circulage is not recommended who have short cervix that is incidentally identified on late second trimester ultrasound scan. RCOG divided the risk factor for preterm birth into high risk and intermediate risk. Women at high risk include those with a previous preterm birth or second trimester loss in between 16 to 34 week gestation, or previous preterm pre-labor rupture of membrane less than 34 weeks. Previous use of Cerclage, known uterine variant, intrauterine adhesion, and history of trachelectomy. That means women having any of these conditions will be included in the high risk, and these women should be reviewed by a preterm prevention specialist by 12 weeks where possible, or with a dating scan whichever is sooner. And they should offer transvaginal cervix scanning as a secondary screening test every 2 to 4 weeks between 16 to 24 weeks. Let's see who are falling into intermediate risk. Women with a history of previous full dilatation cesarean section. That means if any women have a history of cesarean section at full dilatation of cervix, they will be fall into this risk factor, intermediate risk factor. And other risk factors included this significant cervical excisional surgery, for example large loop excision of the transformation zone, or excision depth greater than 1 centimeter, more than one procedure, or a cone biopsy. So any of these risk factors present, they will fall in this intermediate risk, and these women should have transvaginal cervical scan no later than 18 to 22 weeks in a minimum. And these timing are based on a consensus of experts from the UK preterm clinical network. And another important things to be mentioned, that the insertion of a history or ultrasound indicated Cerclage in women with multiple pregnancy is not recommended. Now coming to rescue Cerclage, it's also called emergency Cerclage. So who are the candidates for emergency Cerclage? The women who are having premature cervical dilatation along with fetal membrane exposed in the vagina, they are eligible for offering this rescue Cerclage or emergency Cerclage, and the decision should be individualized, and parents' view should be taken into account. The balance between useful prolongation of pregnancy with its reduced neonatal morbidity and mortality against the possibility of prolonged severe neonatal morbidity in a baby that might otherwise die. The woman's decision should be aided by a senior obstetrician, and this rescue Cerclage or emergency Cerclage can delay birth by approximately 34 days in a suitable cases compared with expectant management or bed rest alone, and it should be associated with a twofold reduction in the chance of birth before 34 weeks of gestation. However, there are only limited data to support an associated improvement in neonatal mortality or morbidity. Let's check the contraindication to Cerclage insertion. So when we cannot offer this Cerclage insertion, if the woman having active preterm labor, that means cervical dilatation is more than 4 centimeter, and clinical evidence of chorioamnitis, continuing vaginal bleeding, preterm premature rupture of membrane, evidence of fetal compromise, lethal fetal defect, or fetal death. If any of these findings are present, then we cannot offer the Cerclage insertion. In this slide, we can see different types of cervical Cerclage according to suture placement. And this can be either in the transvaginal route or can be transabdominal route. And transvaginal Cerclage, it can be at lower level or higher level. When the transvaginal persisting suture placed at the level of the cervico-ischic junction without bladder mobilization, it's also called McDonald stitches or McDonald Cerclage. And if it is placed at higher level where bladder mobilization is needed, it's also called Schroeter stitches. And transabdominal Cerclage can be performed via laparotomy or via laparoscopically. and this suture is placed either pre-conception or after conception. And another we called occlusion circulus. This occlusion circulus is placed around the external os. The theory behind the potential benefit of occlusion circulus is retention of the mucus plaque. Now we will see what are the recommendations during operative and post-operative time. There is no evidence to support the use of routine perioperative tocolysis or antibiotics in women undergoing insertion of circulus. And the use of this perioperative tocolysis or antibiotics should be considered on an individual basis. That means it is not routinely recommended, but it can be given on individual basis. And the choice of anesthesia should be made by the operating team in conjunction with the woman. And it can be either short general anesthesia or it can be regional anesthesia. And it can be performed as day case procedure. And during the post-operative time, the bed rest also is not routinely recommended. That means the patient can perform her daily routine activities. Now the question is, when should the circulus be removed? A transvaginal circulus should be removed before labor, usually between 36 and 37 weeks of gestation, unless birth is by pre-labor caesarean section, in which case suture removal could be delayed until this time. And if the woman present in established preterm labor, the circulus should be removed to minimize the potential trauma to the cervix. And in case of high circulus, when the circulus is placed higher up, then we need anesthesia for removal of the circulus. And all women with transabdominal circulus require birth by caesarean section. And the abdominal suture can be left in place following birth. Here we will see what is the recommendation in case of preterm POM. If any woman develop preterm POM in between 24 and 34 weeks of gestation and without any evidence of infection or preterm labor, then we can delay the removal of circulus for 48 hours, and this is to facilitate in utero transfer. That means if the woman come with preterm POM and gestation is in between 24 to 34 weeks, then we can delay for up to 48 hours to facilitate in utero transfer. But delay suture removal until labor ensure or birth is indicated is associated with increased risk of maternal fetal sepsis, and it is not recommended. That means until birth we cannot wait to remove the suture because it will increase the risk of maternal and fetal sepsis. And given the risk of neonatal and maternal sepsis and the minimal benefit of 48 hours of latency in pregnancy with preterm POM before 23 weeks and after 34 weeks of gestation, delayed suture removal is unlikely to be advantageous in this situation. That means if the preterm POM occurs before 23 weeks and after 34 weeks, in that case, the delayed suture removal for 48 hours will not be very beneficial. So, this is about preterm POM and circulus removal. So, this is the recommendations regarding cervical circulus. Thank you all.